Saptarshi, Biswas, and I sincerely apologize if I just butchered that. From Myrtle Beach, South Carolina, the Associate Program Director of General Surgery Residency, Director of Surgical Research and Stimulation at Grand Strand Medical Center. Did I say that so wrong?
It's everything right.
Okay.
So it's a change of topics, jumping from replating to suspension syndrome. This is something which is very rarely reported because a lot of people don't know about suspension syndrome and the harness hang syndrome, which is like synonymous with it. Different names comes with it. Usually involves people who are hanging with a thread or with a rope or anything, people who are doing construction work at a height, people who are into sports jumping or cave exploration and stuff like that, and they are like held motionless in a particular position for a long period of time. They develop syncopal or presyncopal symptoms, and that can eventually even lead to death. So without any trauma. And so this is an unusual one. I was giving a talk sometime a couple of years back on hanging and near hanging. And as I was researching for my presentation, I came across this suspension syndrome, and I got interested in that, and eventually found out there's like lots of literature which has been, especially in the field of wilderness medicine and stuff like that. I have no disclosure. So suspension trauma syndrome was first described in a report of autopsies in people who died suspended from a harness in Austria and Spain. This was reported in a wilderness conference in 1970, and there was probably 10 people who were involved in this sports activity in the Alps or somewhere, and they all died. They did not die together, but they did die. Some of them were in the hospital after a week or so. Some of them died within the next few hours. But they eventually, all of them died, and none of them had any documented trauma that was recorded. So minimal traumatic injuries concluded that the cause of death was some sort of a shock. They were still not sure what exactly was the shock from, but there was some sort of shock which was involved in that. And so the suspension trauma syndrome, also known as harness hang syndrome, because there have been incidences where the harness that has been involved in people who are wiping windows at a height, or working with high-rise construction, working with tall bridges and stuff like that, they do have the potential of developing those syndromes. And it's defined as development of presyncopal symptoms, loss of consciousness of the human body, if it's held in a motionless position, in a vertical position for some time. So this is some of the predisposing factors. None of them are absolute, but those are the ones which have been cited over and over. And there's a 2006 Occupational Safety and Health Administration, OSHA guideline, which is taken into account multiple times by different organizations all over the world. And they mentioned about if you're suspended for more than 30 minutes, it increases your risk of the suspension syndrome. Although, as it says, it's very unpredictable. Different people have different numbers for that, depending on the age and stuff. Height, 5 feet or more is documented as the height. Age and gender. Gender doesn't have any effect that is documented. Older you get, the poorer the cardiac reserves and the arterial functions, and those are more vulnerable. Weight, increased weight has shown to have been a risk factor. So these are some of the harnesses. I have some pictures of the harnesses at the end of my slides. So these are chest harnesses, which are, again, can be from different types. The dorsal harnesses, which have been mostly studied because those are the ones which are like a strap in the back and then with a strap in the front, in the chest. And then the seat type positioning, those are the ones where you clean the windows or paint height or something like that, and full body harnesses. They have their modifications for safety reasons and stuff. I have pictures later on which I can discuss on those. So discussing about the types of harnesses, because the types of harnesses determine to some extent the injury types and the risk of the suspension syndrome. So the dorsal harnesses, which is again mostly it's the harness which is in the back, and then like straps in the front over the chest wall, and then one along the inguinal region, which is holding your body up. And there's decrease the blood flow, creating functional hypovolemia by limiting the physiological movement of the rib cage and the diaphragm. So this decreases the respiratory volume, and then increases the interthoracic pressure, and then decrease in preload and cardiac activity, cardiac output. And all this help in producing the suspension syndrome and presyncopal episodes and stuff. So Beverly et al. Increased frequency with dorsal harnesses, the increased frequency of death, increased frequency of suspension syndrome with this type of harness specifically. And they did a prospective randomized study of differences according to the type of harnesses. They used frontal harnesses, dorsal harnesses, and a full body harnesses, and they found out that the full body harnesses was the best tolerated. So again, the dorsal harnesses increases the heart rate. There was noted to be a compensatory autonomic response to the decrease in pulse pressure and heart volume. This decrease in pulse pressure, when associated with the presence of dizziness, that eventually happens in these people who are hanging motionless for some time, is an indication for onset of poor cerebral perfusion. From then onwards, it's a pretty significant downhill road for all these people. Frontal harnesses, no significant change in heart rate was identified. On the other hand, the assessment of the map showed an increase rather than like a decrease in the previous one, and seeing a clear decrease in the pulse pressure. So there have been cases where the dorsal harness group, there's an increase in AST seen in the plasma, and the explanation that was given was the compressive effects of the groin straps that is holding the person in place in a hanging position. That causes muscular ischemia at that site, and that can cause a rise in AST. So controversies were significant. We've come up with different opinions, different hypotheses, still not there yet as far as like pinpointing that like what is the causative or reason for this suspension syndrome. One of these hypotheses is the sequestration of blood in the lower extremities with pooling of blood by a deficient muscular pump causing low cardiac output. And this was like for a long period of time considered to be the only explanation. Now there's different theories which come up. Second theory talks about metabolic waste accumulation and hyperkalemia that can cause anaerobic muscular metabolism, and then eventually has its own detrimental effects from there. Another theory is that harnesses with a dorsal hook may be a trigger to postural asphyxia and vascular compression of arteries and femoral veins exerted by the harness in the inguinal region, causing a decrease in venous return as opposed to the ventral hook harnesses in which the effect is less severe. So this is like a schematic diagram which takes into account like some of the hypotheses I mentioned. Like here you can see like there's pooling of blood in the lower extremities, so there is like a compromise of the cardiac output, decrease in preload, and eventually the patient loses diminished blood supply to the brain. The patient loses consciousness, and his head hangs over, the airway is blocked, the tongue falls backwards, and you end up with a respiratory death. So if unconscious, release the harness as soon as possible. So the title of my talk was about the myths, about the evidences. So this was one of the significant myths. In fact, like I've been to some of the EMS conferences and talking to some of the senior EMS personalities. They did mention about the semi-Fowler position, and so they believed in that semi-Fowler position. And for a long period of time, this was considered like the way to treat suspension syndrome. And what they recommend is that like soon after you put the patient down from a harness, You put the patient in a semi-Fowler position by keeping his torso in an elevated position, approximately 30 to 40 degree angle, and slowly moving to a supine position in a period between 30 and 45 minutes. Controversy regarding the initial management, since the lack of oxygenated blood received by the blood during the suspension period is potentially lethal. Now, there are certain groups that says even riskier in place that patients in the supine position immediately after the rescue has been done due to the reflux cause death by producing an acute overload of blood into the right ventricle by massive return of blood. So the right ventricle is overloaded with blood, and that can cause significant overload effects and death from reflux. So they are the ones who are proponent of the semi-Fowler position. But in a study of 10 volunteers who maintained suspended by a harness until they showed signs of circulatory collapse and immediately placed horizontally, it was identified that they did show sinus arrhythmia and ventricular systoles. And all this did show that the rapid venous return of accumulated blood could produce cardiac failure and death. However, presently the paradigm has shifted, and we are going more towards the ATLS protocol. But on the contrary, the paper by Blaisdell contradicted the theory of this reflux death syndrome, and they did the pathophysiology of the hyperfusion syndrome in skeletal muscles, which causes ischemia, and this says that as the ischemia progresses, less and less blood flow increases the edema and increases the effect of the ischemia and eventually necrosis. So their postulation was early restoration of blood circulation limits the additional loss of volume in the interstitium by reducing the edema. So the authors suggested that the patient should be released from the harness and placed supine as soon as possible to restore oxygenated blood to the damaged muscle. Maintaining this vertical position in these patients or a semi-Fowler position in these patients will simply worsen the muscle damage and hypovolemic shock. So the patient ideally should be transferred to a hospital and should be followed with the guidelines for ATLS. This is like a quick cartoon about the management protocol. If there's a rapid descent possible, obviously the patient is conscious or unconscious, they will call for help. Make sure that the patient can be transferred to a trauma center, ideally with a dialysis facility, because a lot of these patients develop renal failure and may require dialysis long-term. And or if the patient is not capable of having a recent rapid descent, then obviously a call for help, and that needs to be arranged. If the patient is conscious, then there are different types of adjuncts to the harnesses that has been added now commercially, which can move your legs so that you have harnesses, you have the harnesses in the strap in the chest, in the groin region, and you have an adjunct which can you can buckle into your foot, and then you can keep moving your legs so that you do not lie motionless in a vertical position. And that can help also in the outcomes. If the patient leg movements, as I said, is significant, and that can improve the outcome of this patient. If the patient is unconscious, obviously, as far as the patients are concerned, the patient is a significant risk for death or anarchic brain injury, so that needs to be transferred as soon as possible. So the management protocol is more or less the same. We normally follow the ATLS protocol, starting with primary survey, secondary survey, as in any trauma facility. Start with ABCDE, and then make sure that the patient doesn't have any trauma to supplement to this suspension. And then start with hydration. Make sure that the patient is adequately resuscitated with crystalloids initially. As I said, some of them develop renal failure. In fact, quite a significant number develop renal failure, so that needs to be resuscitated adequately. They can be hypoglycemic during this time, so hypoglycemia should be corrected. They have electrolyte disbalance, which should be corrected aggressively. Care should be taken to replacing potassium aggressively, because they can have hyperkalemia, and so unnecessary aggressive replacement can cause detrimental effect. Obviously, pain relief, because that adds to the stress and anxiety and all adds to the problem. Important to do EKG because that will show peak T waves for the hyperkalemia, QT prolongation, widened QRSS complexes, those to be medically managed. BP should be monitored very closely because high BP can indicate hyperkalemia. We need to look into the CMP, BMP and correct it adequately. Again, as I said, should be immediately transferred to a trauma center with adequate facilities, probably with dialysis facilities. Rhabdomyolysis is a complication, is a known complication, and most of these patients do develop renal failure as a complication. So you need to monitor them and adequately manage rhabdomyolysis with volume resuscitation and monitoring myoglobin and CK. So this is the study from the Wilderness and Environment Medicine Journal, which brought more clarity to the suspension syndrome. So the data was, the authors examined widespread belief that the blood pools in the legs when an individual is passively suspended. So what they did was they did study on the superficial femoral vein, which is like technically a deep vein. And ultrasound studies were done on the distension of the superficial femoral vein. And while study participants were passively suspended, the vein returned to normal once the participants were lying down. In normal circumstances, the muscle contractions of the legs squeeze blood upwards past the one-way valve back to the heart. So their studies confirmed that widely held hypothesis that moving the legs could restore circulation of this pooled blood. The ultrasound study showed that stasis of blood in the vein while participants were passively suspended, followed by rapid resumption of venous flow while movement. So this contradicts the Fowler position that like it should be in a semi-Fowler position before your leg supine. So this says that like there is a rapid restoration of blood flow soon after and without any significant detrimental effects. So the true incidence of suspension syndrome is unknown and it's rare. This study is consistent with other studies suggest that 30% of the climbers and others suspended on rope are at risk. So some other studies which again debunk the persistent myths. One of the myths again, as I said, rapid venous return after lying the victim flat could overload the right side of the heart, causing immediate rescue death. So there have been echoes done on those heart, showing that like the heart shrunk going to the venous pulling, returned to the original size after the rescue without any additional enlargement. This notion of fainting while suspended passively on the rope was due to insufficient cardiac preload owing to the sequestration of blood in the legs and possibly from a Biswas gyrus reflex was probably not right. And we need to look into that. And then this echocardiography on those subjects confirmed that the cardiac preload remained adequate soon after they were put back in supine position. So instead, they opined or they postulated that this was a syncopal episode where it was a neurally mediated phenomenon and it happened with one of the triggers being the orthostatic position of the patient. Some of the other myths that have been put forward that femoral arteries and femoral veins are the causative organisms, causative agents for harness pathology or harness gang syndrome.
1 minute.
And this, so it's now clear that based on ultrasound imagery that the femoral veins and femoral arteries are not affected by sit harnesses, and passive suspension is the problem rather than compression of the vessels by the harness. So harness management should not delay rescue. It should in fact be one of the first priorities. Passive suspension should be taken seriously, and one of the things that we mentioned, the patient, the person, if it's able to, should keep moving their legs while awaiting rescue. Victims of syncope due to suspension should be placed flat immediately after exertion, and ATLS management protocol should be followed. So these are some of the pictures I was talking about. The first one is one where it's a sit type, and these are like some of the ones where you are like holding your chest. These are dorsal harnesses with a chest strap, and some of them with a groin strap. There's the ones like which can cause restrictions in blood flow if you're holding in a motionless position. And those are some of the adjuncts I've mentioned, where you can put it into your foot and move your foot so that like you're not lying in a vertical motionless position. Thank you.
questions at the end. We went over a little bit. Okay. Thank you so much. So our next speaker is Dr. Buckley from Austin, Texas. I personally asked him to give this talk because practicing in a rural area, a lot of times we end up being the GI doctors, and one of the most common things we deal with is GERD. And so I asked him to give this talk, an update on GERD, the ACG guidelines, medical and treatment. He is the Associate Professor of Surgery from the University of Texas, Dell Medical School.
Thank you. Thank you for the kind invitation. I really appreciate it. I don't know that I've given a 15-minute talk in a while, but I will try and stay on time. Just jump right into it. So, GERD therapy is now 2023. Primarily medical, right? But PPIs don't do everything, and they can't do everything. And so we know from the GI literature that about 30 to 40% of patients have symptoms on PPIs, so breakthrough symptoms, etc. They're unhappy. And really, surgical therapy represents less than 1% of what we do, despite the fact that there are 18 million Americans out there that probably could benefit from anti-reflux surgery today. So we're going to delve a little bit into why that might be. These are my disclosures. So what is GERD? Obviously, it's just reflux of gastric juice into the esophagus. It's largely a mechanical problem, despite the fact that we use PPIs to treat it. And what are the causes of GERD? And so because it's a mechanical failure, we look at the crural diaphragm, so you can have a hiatal hernia. That's going to put the lower esophageal sphincter in the chest, which is a negative pressure zone. We learned a lot about the chest this morning. We have the flap valve, or the angle of His, that prevents reflux ache. And then you have the sphincter itself, which is really the sling fibers. And so our goals of anti-reflux surgery are to restore normal anatomy. So you can see the endoscopic view of what the flap valve looks like. And if you're in a rural setting and doing a lot of EGDs, this is kind of what you're looking at. That's a pretty competent valve. This would be obviously an incompetent valve. So looking at a small hiatal hernia, you can see the rugal folds going up into the chest, and this is going to be a problem for that patient. So how do we start to evaluate patients? And I think that whether in a rural setting or in an academic center like myself at Dell Medical School in downtown Austin, where I've got all the neat things to do, we can still do good evaluations everywhere. So the first thing we look at is really the symptoms. And, so you come in, you say, I've got heartburn. Okay, that sounds terrible. You're in the typical symptom zone. We then ask them about regurgitation and dysphagia. But a lot of people present with atypical symptoms, right? So they've got ENT or upper airway symptoms, even cardialgia, which is really what heartburn is. They can have all sorts of things. I won't go through this study, but it really shows that our pH testing has really never correlated with symptoms. So you can have a Demeester score of 75 and have barely any symptoms, and then some people will come in thinking they're dying, and their Demeester score will be 16, 14.7 being our threshold for surgery. How do we work these up? Well, the first thing we do is an anatomic evaluation. And in our clinic, what we do is everybody that comes in, new patient, they get a video esophagram. In fact, we get something called a marshmallow bagel esophagram, where they're swallowing liquid and solid upright, and then we prone them and put them in Trendelenburg, and we'll have a video of this in a sec, to really see if their swallowing is relatively normal, and also it'll show us how to put it. Let's see if I can just get to that video. So this shows one of our esophagams, and you can see there's some rugal folds in the chest just above the diaphragm. But when you prone them, here's that same patient, you can elicit that hernia. So this is a good size sliding hiatal hernia, and if you've got fluoroscopy in your hospital you can do this exam and really get a lot of great information that's been studied at USC and by ourselves, and it really, it's not a replacement for motility, formal motility, and I don't want to suggest that, but you can really get a lot of good esophageal function from having swallowed marshmallows and bagels. Happy to discuss that. I'm a member of the American Foregut Society. I'm actually a founding member and on the board. And when we get to the guidelines, I'm happy to say everybody on the guidelines, on the ACG, the American College of Gastroenterology guidelines, is on our board at the American Foregut Society. And so we've spent a lot of time trying to rejigger you may have heard of the Hill classification. It's a classification of how to look at the lower esophageal sphincter endoscopically in retroflex views. We've come up with our own grading system that we think is a little bit more manageable. It's been really adopted by the GIs as well, and at least at the board level and within our society. And so you'll hear maybe more about the AFS classification. I won't go into it exactly. So next, we got to look at the function. And so we, again, have the video esophagram. We have a neat thing called EndoFlip at our facility, which is not necessary, but it's able to get a distensibility index of the lower esophageal sphincter. Super helpful in the operating room when you're creating wraps, but also very useful in looking at achalasia, EGJ outflow obstruction, things like that. Obviously, we want to sometimes get gastric emptying studies, and then you really need to have high resolution manometry for a lot of these patients. Not every patient, but a lot of them. And so finally, that evaluation, we need to look for objective evidence of GERD, especially if we're going not for a structural problem like a large hiatal hernia, but rather for GERD itself. So we have our LA classification of esophagitis, looking for Barrett's, doing biopsies if indicated, certainly trying to rule out a cancer or a peptic stricture. The obvious goal is to get somebody into your clinic before you end up having to have bad Barrett's or bad esophagitis, etc. Okay, so let's actually look at the guidelines. Again, these are the GI guidelines. They're new as of 2021. I'll just suggest here that, for a long time, ever since the introduction of PPIs, the gastroenterologists and the medical community has said, hey, look, we've got GERD licked. We don't need you silly surgeons. And so everybody's been treated with PPIs. And PPIs are effective. I treat people with PPIs every single day. However, the results of surgery, while if you look at the literature are excellent, out in the community of GIs and primary care doctors, they are very suspect of what we do. And that's partly because a lot of surgery is being done and by folks that don't do them all the time. So these surgeries can be done anywhere by anybody who's well trained. But you have to do a fair number of them to stay good at them. So let's look at these. So this is really interesting, and this is a sea change from what we have been, the way that things have been practiced in the past. I come into a clinic, anybody's clinic, I've got heartburn, okay, that's terrible. I'm gonna put you on a PPI for 8 weeks, okay? I did great, fantastic. We're gonna take you off of that PPI, you're done. And then if I come back and I say, hey, my heartburn is back, that person's supposed to say, okay, that's terrible. We're going to get you an EGD. It can be done by your friendly rural general surgeon. It can be done by a gastroenterologist, but you need to have an EGD and a pH study off of PPIs. That is a major league sea change for the way we treat GERD. And then, if you've got esophagitis, especially really CD, they put in here B, I don't agree with that, but CD esophagitis, that is diagnostic for GERD, period, you've got it, okay? If you're normal, then you get that pH monitor. In our institution, we put them in everybody, and then if that's abnormal, so a Demeester score of 14.7 or greater, then you've got GERD, boom, done. So nobody should be on PPIs longer than 8 weeks without a pH study. So if you're talking to your gastroenterologist, just say, hey, I was reading your guidelines the other day. This is interesting. You know, maybe we should practice to the guidelines here, or what do you think? Very huge change. For atypical symptoms, it's even more aggressive. You got atypical symptoms, effectively, they're going to put you on PPIs for 12 weeks, but then take you off, boom, reflux monitoring. So, but to someone else's point earlier, I think Peter reads, if you want my slides, please do. There's a lot of hidden slides in there too, so you can see a lot of the way we think. So you have those extraesophageal symptoms, you get your reflux monitoring, you either have GERD or you don't, and then you move on. So PPIs. Again, PPIs are great. We use them all the time. It's key to understanding the effective use of them. So PPIs, when you take them, they can only bind to non-active pumps. That's why we always say you got to take them about 45 minutes before your first meal in the morning, right? If you had a cup of coffee and had a donut, your pumps are active, that PPI is not going to be effective. So, you know, we spend a lot of time maximizing the effect of PPIs, making sure patients take them correctly. Interestingly enough, really nighttime dosing is the best, meaning before dinner. But we don't really practice that way, and no gastroenterologists practice that way because it's just hard to get people, they come home from work, they're doing whatever, they forget to take their medication. So we're just going to have them take it at breakfast. And then you can see what the, when you do double dose, it's even more. This slide is busy. Hopefully it projects pretty well. But this really talks, I see patients all the time, oh, I'm going to die, I'm going to get dementia, my mom had dementia, and I don't want to have dementia, so I need to be off my PPI. That's a joke. So this kind of goes through what is real and what is not. Every drug has side effects. PPIs are largely safe, especially single dose. I start to worry about double dose PPIs in patients that, females that are postmenopausal and things like that. If you've got kidney disease, then we start to look at it. But really, most of the things that are out there, so, you know, that makes the news and a headline or something is really not accurate. All right, medical versus surgical therapy. So I kind of suggested that, you know, we maybe haven't done a great job as surgeons in really controlling who does these operations. This is a paper, I'm just going to have a couple of papers up here that talk about, this is in the GI literature and in the medical literature. An esophagus disabled by an inappropriate or dysfunctional fundoplication is a terrible price to pay for control of acid reflux. Ouch. Joel Richter is a friend of mine, famous gastroenterologist, and says that surgery offers a unique opportunity to cure the disease. So they admit that when it's done well, you're fixed. But success depends on correct diagnosis and experience of the surgeon. Disadvantages include frequent postoperative complications, ouch, that shouldn't be, possibility of death, for the love of Shiva, I mean, come on, and unknown long-term durability, ouch. And so these heavy hitters, gastroenterologists write these papers, and their fellows go out and they're like, never send someone to a surgery. So this is what we're trying to do as surgery. It's pretty simple. That's a post-fundoplication retroflex view. You can see that it is a super physiologic valve. This happens to be a Nissen, but it is super physiologic, and that's where really surgery, if it's not done perfectly, because you're making it the patient super physiologic, you can get into trouble. It's just a couple of different types of fundoplications. And so just going back through the literature, and there's been literature ever since really comparing surgery against Tums and Rolaids, but this was one of the first comparing surgery against PPIs. And this is a combination of surgeons and gastroenterologists done in Europe. And really, to get into this trial, you had to be doing great on your PPIs. So that was the only way you could even get into the trial. And so this showed equivalency between surgical treatment and PPIs for people that were already doing great on a PPI. So the gastroenterologists say, well, we don't really need surgery because PPIs do great. But the surgeons say, hey, we're at least as good as PPIs for those that don't want to be on it. There were a bunch of papers since then, but this is probably the most significant. 2019 New England Journal of Medicine, Dr. Speckler up the road in Dallas did a prospective randomized trial in veterans who were suffering from GERD. And basically, after they went through all the testing, just like we discussed, and they identified patients who had GERD and were good surgical candidates, that they found that surgery was superior to PPI therapy. So that's one of 3 prospective randomized trials that looked at surgery versus PPIs. Even for patients that are doing okay on meds, surgery is superior. 1 minute, oh boy, we're in trouble. Okay, so these are the actual written recommendations from the ACG. Recommend that surgery performed by an experienced surgeon is an option for long-term treatment of patients with objective evidence of GERD. Huge sea change. So, hey, look, if you're on a PPI long-term, you should be sent to a surgeon to at least discuss it. They look at magnetic sphincter augmentation, Roux-en-Y for recalcitrant GERD, especially in a high BMI patient, and then also the TIF procedure, if you've ever heard of that. This is important. The outcomes are better in high volume centers. I feel like you need to do about 25 a year, and last year we did 417 between my partner and I. We're pretty high volume, but really we do a lot of specialized surgery. I encourage you to look at your outcomes. So these are instruments that you can use to see how you're doing. We report on this every day. We have high confidence in our GIs because we follow our patients forever. We get these patient-reported outcomes and we can say, hey, here are our results. Let's see. I'll just zip through this. Roux-en-Y is an option. My partner just presented on this yesterday. Looking at leaving a fundoplication intact and doing a Roux-en-Y after that for GERD. And I will conclude there. Don't know if we have time for questions, but I'm happy to.
All right, we will hold questions for the end. She's kind of the boss. The next speaker, I'm pretty excited about. He's speaking on rural trauma, the importance of pre-hospital inclusion in research planning, training, and operations. He just happens to be my father-in-law. He is literally the guy that wrote the book. He wrote the ATLS manual, and he was a fireman paramedic, the chief of the fire department in Chicago Heights, literally the south side of Chicago. And after he put that hat down, he has been the director of the International Pre-Hospital Medicine Institute, trying to improve trauma care everywhere. So this is Will Shaplo.
Guilty as charged, thank you. This will be largely a non-surgical discussion, but what I want to look at here is a problem in rural settings in trying to do the best you can for your trauma and your traumatically injured patients. There are a lot of factors involved here, and we'll look at some of the things here. Some of the issues that are concerned. One is time. Time, obviously, is the enemy of trauma. We go back to the things that we learned a long time ago, concepts that have been debunked to some degree over time, like the golden hour, emphasize the importance of finding out what's going on, do the right things as quick as you can, and get this person to definitive care. Rural trauma presents problems on both ends of that. On the one end, definitive care might be prohibitively distant. I'm working on a project in Montana, no level one trauma centers. You know, that paradigm shifts significantly when we try to think, what's the best thing we can do for people? And by the time we get to the end of this talk, I think we'll try to put some of the things that we've learned, sometimes not direct research on rural trauma, but research about what happens in the first few minutes or the first hour of an injured person that we've learned from the military that we can apply to solutions in rural environments. Response times are tough. In some situations where I worked largely in urban settings, and I was proud of the fact that we could get to the scene in 3 to 4 minutes. In a bad trauma case, I was in the hospital in 10. That was a great environment to work in. I spent most of my clinical career in that kind of atmosphere. When you look at rural environments, Oftentimes, just to get to the scene will take an hour or more. And then the hospital, any hospital, might be an hour or more away. The project that we're working on in Montana is significant because if we look at resources, which are going to be a problem in a minute we'll talk about, is that crew, for that volunteer community that picked up that patient and took them to the closest hospital they could, now has to stay there. So after damage control is done and they stabilize as much as they can, they then take that patient to the next level, which might be hours away. So these resource issues that we're going to talk about are important because if that ambulance leaves that community, who's going to cover it out? They're gone for 5 hours. I talked to some folks in North Dakota on a conference I was working on, and this is a couple decades ago, but it was a significant awakening to me when I went there and they said, well, what we do when we get our ambulance is I stick an envelope full of cash in the glove box because they have to buy gas and food, and we'll see them a day later. These realities in rural environments, extremely rural environments, really give us pause in what we typically think is the best thing to do and what we have to do in those situations. And what I'm proposing here, that, and by the end we'll review this, is that we look at what our situation is, we identify the resources, we identify the stakeholders and the players, and we bring them all in. Because in some cases, your resource that you're in charge of might be field management, and in another case, you're at the hospital. But at the hospital, in the community, you may have to do something to try to assist those field resources so that you can get things done and recover. And we'll talk about some more of these as we go through. People. One of the things that we find out, and I remember in my paramedic training, which was in the 70s, it was a while back, a lot of folks thought that paramedics was a luxury of large, wealthy urban communities, and that for the most part, basic life support was enough. Turns out, research increasingly, in the current sense, is telling, yeah, basic life support is most of what people need in the field. The incidents call for and benefit from many of the advanced life support things we do. Even routine things like intubation aren't having the effect on patients that we anticipated, and simple things work. I do another talk at conferences that I call, Is It Really That Simple? And what we get to at the end of that conference, that discussion is yes. The things that we do for patients that make the most difference are very simple as far as pre-hospital is concerned. Research. One of the things we'll talk about, and I do have some research that I'm going to pull, is there is a lack of data on rural environments and what we can do. And that lack is from a couple of different perspectives. One, pure science, the studies are small. There's just not enough samples, not enough cases. In an urban setting, for instance, I might have seen mid-shaft femur fractures once or twice a year while I was doing 20 cases a day. In a rural setting, what are they going to do? That's further drawn out. So for them to be ready for really complicated cases, it's tough. And for us to study it, to see what the results are, even more so. The studies are relatively small. They hint at things, but we really can't say definitively what we've learned. So lack of data, small studies, we have to get to a sense of planning and training and making sure we're all on the same page. All of us to do these things within our own silo, whether we're at the hospital or in the field, is not going to solve the problem globally from end to end. It's like there's a thing we used to do in Kansas, and they had a couple of level 1 trauma centers, but they would do rounds. And what they did was they'd bring everybody in from the field all the way to rehab and talk about the cases. And in those discussions, they would come up with things that they could do to improve deficits that might be identified at any point in the care of that patient. I would like to encourage you to look for those opportunities because you're going to find the effects that you can have. I mean, if you look at trauma death, and we'll talk about this as we go through, there's a high curve of those that die immediately or before much care is given. We used to talk about the trimodal distribution of death, where there was death within the first few minutes, then death up to 2 to 4 hours, and then death up to even days afterwards. The shift is occurring now, which might be due to several things. That we train better, we're working faster. That section in the center that used to be up to 4 hours has shrunk to 2 hours, and more of the deaths have shifted to an immediate zone. That doesn't mean more people are dying, that means fewer people are dying in the other parts of that trimodal distribution. So we can learn some things about what's going on, and it keeps getting us back to that first period. What's happening right now, and can we care for those patients? And we'll talk about that as we go through this. Forgive me if I'm all over the road, but it's kind of an exciting topic. I'm hoping I can get something out. This study looked at an association between response time and motor vehicle crashes. Now this data, it makes a pretty clear statement, but there are other studies that aren't quite as clear. This was a population-based study, looked at 2,268 US counties. So they're getting into the huge trauma database and looking at all of these cases that satisfy 239 million people in this period between January 1st, 2013 and December of 2015. They looked at this data through 2018, excuse me. So they had 2,214,480 ambulance responses to motor vehicle crashes in this period. Median time was about 9 minutes. Longer response times were significantly associated with higher rates of motor vehicle collisions. And I think this is directly attributed to what kills most trauma patients, and that's bleeding. If you don't stop the bleeding, if they don't get blood, if they don't have definitive care, they're going to die right within that time period. After adjusting for measures in this, they said that in all of the things that they talked about access, they were able to conclude in this one that it's consistent in both rural, wilderness, and urban and suburban settings. A significant portion of motor vehicle crashes were associated with prolonged response times. So if the response times are longer, those people that are dying within that first period of trimodal distribution are going to die. And we're going to talk about the science, about the care for those that's leaning us towards what we can do for that particular population. They concluded here that longer EMS response times are associated with higher rates of mortality, which I pretty much described. This study here, in J-Trauma, looked at identifying patients with time-sensitive injuries. Now, this is another interesting thing to discuss. Most of us, at one point or another, if we're involved in pre-hospital care, we're looking for that 8-minute model that was identified in Seattle years ago from studies that were mostly about out-of-hospital cardiac arrests. That if you could get there with advanced life support within 8 minutes, that they're going to have better survival rates. So we all built off of that model of 8 minutes. Now, replicating that in other EMS systems, basically information comes out and says, as long as you're there within a half an hour, everything's probably pretty much the same. But if you squeeze that data down to people with critical injuries, there's actually a benefit if you're there within 3 or 4 minutes. So the data is kind of funny at some points, and you have to sometimes squeeze it a little harder to learn things. So this particular one looked at the association of mortality with increasing pre-hospital time. Now, the difference between response time and pre-hospital time is this is total. You know, how long from the event to the time that they're actually at the hospital. That's pre-hospital time. So they looked at patients that were 16 years or older in NTDB from 2007 to 2015. They used a common spline analysis to identify the inflection and where pre-hospital time is more likely associated with mortality. Now, as with some of these studies, the first slice is not what you're looking for. This one, pre-hospital time at 30 minutes or less were associated with higher mortality. And here they said pre-hospital time was not associated with mortality at that point if the score was 9. This interaction demonstrated increased mortality with pre-hospital time with systolic blood pressure. So again, first slice wasn't helpful, squeeze it a little harder. And here if you look at patients that have systolic pressures less than 90 and Glasgow scales that are less than 8, it contributed significantly to patients that weren't going to do well. So here they talked about that. Again, patients with pre-hospital hypertension, Glasgow coma scale less than 8, non-extremity fire injury have higher mortality. This study looked at the effect of emergency medical system transport time on clinical decline in rural systems. This is an institutional review board that looked at retrospective analysis. And again, one of the problems with pre-hospital science is everything pretty much is a retrospective study. It's hard to do double-blinded randomized studies on people and tell them you're going to do a critical intervention or you're going to do something that may or may not be a critical intervention in those populations. It's hard to get people to sign off on it. So this study, almost half of the patients, one of the things remarkable in this is that half the patients didn't go to the right facility. And they figured that again, that comes into planning and communications and availability. What's not clear is when they say not the right facility, was the right facility available? And was that reasonable for them to go to another facility? So this one they thought points out that in rural states, injured patients that fail to read level 1 and 3 are going to do well in less than half the time were they arriving at the right facility. And again, that would come down to an analysis of the communities and if there were better possibilities or potentials. And again, rather than decline after an hour, this data showed an increasing proportion of patients experience clinical time throughout their care and transport. This study looked at trauma patient transport times despite, this is an interesting one. Those of you that work in urban areas know that from time to time, people start to debate what the perfect solution is for the number of trauma centers in a given community. This particular study looked at that a bit to say, we've got all these trauma centers, we should have solved all our problems. Does that work? This aggregated data, level 1 trauma center admissions in Arizona between 2009 and 2018. They looked at patient demographics, transport times, and injury severity. Data included summarized 266,605 level 1 trauma admissions in Arizona. The number of state trauma centers during this time increased from 14 to 47, with level 1 centers increasing from 8 to 13. So that's a significant increase. So what they thought would happen is that we're going to have much better numbers. Median transport time from the injury to level 1 remained stable. So there was no great change in the amount of time it took to get in. In rural areas, transport times for these is approximately double, but also stable. Transport times for cases requiring inter-facility transfer before admissions increased by 0.3. So not looking like it had what the assumed effect would be. Despite threefold increases in the number of state-designated trauma centers, transport times not decreased in urban and rural areas. This highlights the need for regulatory oversight regarding number and geographic placement of state-designated trauma centers. This comes into that conversation that we've talked about. Pre-hospital care providers that don't see a lot of patients might not be really good at some of the critical interventions they have to do. We had a conversation about intubation. Pre-hospital intubation, studies have shown that if you're going to be a person who intubates pre-hospital, you should be a master at the skill, not somebody that gets to do 3 in a year. Same kind of thing here. If we've got that many trauma centers that the population of trauma patients is distributed so far out, the skill of those institutions might be subject to not being able to advance as far as it could because of not enough patients to do so. So what I'd like to bring this down to is if I were to go back to, sorry, I don't cause a seizure here. So. If I look at these problems that we identified, the studies, like we say, are few and far between. Sometimes the data is difficult, even when you extrapolate it out to long periods of time. The frequency just isn't there for us to get some of the things we need to know. If we look at these things, if we look at what's killing trauma patients in rural environments or in any environment, we're talking about loss of weight. And so much so that we changed the approach of the way we teach people. We learned this from TCCC, or Tactical Combat Casualty Care. That has now found its way into all training of EMS personnel in the field, whereas we used to teach the ABCD paradigm. Now we talk about XABC, or we use a term called MARCH, where massive hemorrhage is identified and cared for first. Now, in looking at that and the things that we can do, the military, again, provided lots of studies for people who were horrifically injured and needed attention in this regard. So direct pressure, obviously, is something that we do for all of these patients. Hemostatic dressings, when direct pressure is difficult or impossible. Tourniquets, safety use, can be used for large things. The idea of caring for people who are bleeding severely in the field and in a rural environment is going to be even more important to look at those patients like you're in a tactical environment, because the level 1 might not be available, level 2 might not be available. So what are we going to do for these folks? Well, one of the things that we taught people is save every blood cell. So if you're in the field, find the bleeding, treat the bleeding effectively, and then if you're going to start doing IV fluids, remember what you're doing and what you're not doing with infusing IV fluids in the field. And these collectively learned teams from pre-hospital all the way to rehab care look at those types of things and we talk to them about infusion. Whereas when I started out, we would put 2 large bore IVs in the arms and we would run IV fluid in as fast as it could go. Now we're talking about bolus 200 cc's, keep the blood pressure down between 80 and 90 systolically, because the oxygen carrying capacity of IV fluid is 0. And if you run enough in, you're going to flush out all the red blood cells and you're going to kill them. And these are these are big changes. You know, if you look at what we were doing 30 years ago, and when we're looking at these types of situations, you're really in a remote situation. That means that we really have to manage saving every blood cell as possible, and working as a team with the community hospitals, the response teams, and looking at the types of patients they got, and how we can train, how we can practice, how we can do things to make sure that these patients are adequately treated. Internal bleeding has been a problem, and again, just about this, it's working out good. One of the things that we played with for years is internal hemorrhage. Obviously, if I can identify the bleeding externally, I can manage it. The problem has always been with trauma patients, particularly when we're trying to make field assessments, is you can't see all the bleeding. So what do we do when we know? If you don't see blood and they're still in shock, they're bleeding someplace else. Over the years, people have experimented with things. When I first trained, and for many years we used, they called them military anti-shock numbers, and pneumatic shock transfers. Frankly, that device disappeared rather quickly based on a single study. There are now devices coming out they call abdominal tourniquets, which is basically the abdomen section of an old mask suit that they're putting on patients to try to compress the abdomen. They're coming up with other devices to try to do this. If we can compress the compartment, can we control the bleed? Not sure where those are going. There have been 2 devices in recent time that looked at trying to compress internally. One was injectors, you may have seen these, where you inject dressings into the abdomen, they absorb the blood and they compress. Those seem to work okay, but I've talked to surgeons who were uncomfortable with being able to get at every dressing and remove it, and sometimes they'd be left behind. There's a new device that's showing some promise where you inject, basically it's like a polymer that expands and compresses the internal abdomen. It comes out as a single piece or pieces that when that patient makes it to surgery. So I guess why I bring these things up is if we look at the problems that we face in rural trauma, and again, from my perspective as a trauma nurse specialist and a firefighter and a medic, I want to make sure that I'm doing everything I can for our patients to get them to you. We want to make sure that we look at resources that are available to us and train our people to do whatever they can to control the hemorrhage. Don't do anything to waste blood cells. Get them to where they're going to do where they can do damage control and figure out what the next level of care is. And that means working as a team. That means those of you in the hospital have to understand what's going on in the field, work with your responders, talk to them. I can tell you that the systems that I worked in when we went out and did training in the actual fire departments with our surgeons, they loved it. Providers could not believe the opportunity they had in talking to their surgeons who are going to ultimately see their patients, and they want to participate. If you as a surgeon came out there and told them everything you're doing is wrong, this is what I need you to do, they're not going to violently oppose you. They want to be on the team. They want to do what's going on and what you need. So all this, there's 10 pounds of stuff in a 5-pound bag, I know, but I wanted to talk about all these elements and the importance of bringing everybody into the room, talking to them about our patient load, what our resources are, and what we can all do to help each other. Because frankly, the more I go out there and I talk to these poor guys, that the ambulance leaves town and they don't have an ambulance until it comes back. Those kinds of things mean we all have to pull together on this stuff. And with that, I thank you for your time.
I just want to say, it also very much depends on where you are. So, you know, in Chicago Heights, the paramedics were firemen. Out where I live, sometimes it's just volunteers, and other times it's just basic life support. So it is really important to get involved and involve this whole team because they don't know any better, you know, and so we need to get this whole collaboration together because, you know, you have what you're working with and you need to, you know, you can't expect them to do things if you don't help them and teach them too.
I'd like to welcome our next speaker. This is Dr. Riley Grogan. He's a 4th-year general surgery resident at Gunderson Health System in La Crosse, Wisconsin. He's also the state surgeon for the Montana Army National Guard. He's currently applying for a trauma critical care fellowship with plans to return to his home state of Montana. Today he'll be comparing his training at Gunderson Health System to that he experienced in rural Kenya on a rotation that he was part of last year.
Yeah, that last talk was particularly interesting to me, having grown up in rural Montana and having started my medical career on an EMS service in rural area. So, thank you. I have no disclosures for this presentation. Objectives are to review a brief history of the rural surgery training model at Henderson Health System, briefly explore the history of PACS and surgical education at the ICS-United Hospital in Kenya, review the impact of Henderson's international elective on its trainees, and lastly, identify some common factors that have allowed both programs to succeed in addressing rural healthcare disparities both domestically and abroad. So it's no secret that there's a shortage of rural physicians in the U.S. Rural areas contain roughly about a quarter of the U.S. population, but these same populations only have about 10% of the physician workforce. It's estimated that 14,000 to 17,000 physicians are needed in order to give rural populations the same access to care. It's important to recognize that this isn't just limited to primary care shortages, it also affects general surgeons. Approximately 87% of general surgeons are practicing in urban areas, and 4.2% of general surgeons are practicing in small, isolated areas. Efforts by Henderson Medical System have tended to address this disparity. Dr. Adolf Henderson in 1891 came from Oslo, Norway to across Wisconsin to establish a practice. Owing to early innovations in surgical care and healthcare delivery, we recognized an opportunity to provide surgical education and would accept visiting surgeons from Norway as well as throughout the U.S. to train underneath them. The formal residency program started in 1957 and then gained full accreditation in 1974, shortly after the Institute or the advent of ACPA. Since then, Henderson's reputation has grown in terms of being an independent academic rural surgery training center. This has ultimately resulted in Henderson being one of the preeminent rural surgery programs recognized by the ACS Rural Surgery Advisory Council. Henderson graduates practicing rural surgery is really a source of pride for our institution. Approximately 3/4 of our graduates enter general surgery practice, and about 2/3 practice in communities less than 10,000. This is a reverse of the national trend. To the right, you can see where Henderson graduates have gone on to establish their first practice. And it's important to note that even though we've been successful in producing rural surgeons, it hasn't been without challenges. Seeking to further improve recruitment of rural-minded trainees, former program director and current DIO, Dr. Ben Jarman, conducted a study trying to identify factors that correlated with the decision to practice rurally. What he found was that attendance at a high school or university in a rural setting, partner or spouse that grew up in a rural setting, participation in rural medical school clerkship, and completion of surgical residency that had a commitment to rural surgical training all correlated with the decision to practice rurally. In an effort to expand our mission to train rural surgeons, international electives were established in 2008. These were established to, in essence, practice what one of my mentors referred to as rural surgery in extremis, hence the name of this presentation. Since 2008, independent global organizations have been utilized to provide experiences in Nicaragua, the Dominican Republic, Ethiopia, Kenya, and Ecuador. During the COVID pandemic, a domestic international experience is actually established in Fairbanks, Alaska. These efforts have been augmented by a formal pathway through the American Board of Surgery as well as ACPA. One of our graduates and current faculty members, Dr. Brendan Esquivel, conducted a study in 2018 looking at the effects of these electives on its trainees. What he found was that 93% of residents completed a new operation for the first time. Residents gained insights into a broader spectrum of surgical pathology. 100% reported positive impact on their commitment to serve in underserved settings. As previously mentioned, a significant portion of the graduates go on to practice in rural communities where they may be the only surgical provider. So broad spectrum training is important for us. What he found was essentially these international electives further expand our exposure to surgeries that we otherwise may not be exposed to. As part of this curriculum, I was afforded the opportunity to travel to Kenya for an international elective. And I think it's important to establish a context for the community that I was placed in. Low and middle income countries represent about half of the global population. Yet these populations only have access to about 20% of the global physician workforce and 17% of the global surgeon workforce. It's estimated that today about 56 million people are in need of surgical care, yet 92% of these people do not have access to care that is both timely and affordable. The World Health Organization recommends that one surgeon per population of 20,000 people. In most African countries, that number is one surgeon per 250,000 people. In some countries, it's one surgeon for every 2.5 million. In respect to some of its neighbors, Kenya is actually fairly well off. Healthcare expenditure makes up a higher portion of the GDP expenditure. There's roughly 2 physicians per 10,000 residents. But it's important to note that disparities still exist within Kenya. First, there's limited access to care. A significant portion of the population lives greater than 60 minutes away from a healthcare facility. Considering that 31% of private facilities are located in the capital of Nairobi, this represents a major logistical challenge. Picture this, Kenya is roughly the same size as Texas. Now imagine 31% of facilities located here in San Antonio. You get a sense of the geographic challenges that exist there in Kenya. Healthcare resources are not evenly distributed. Most public institutions are staffed by general medical officers without some specialized training. Access to surgical care is even more ubiquitous. Most surgeons are located in major metropolitan areas owing to resource investment. There are variations in the standard of care across Kenya. This is regionally as well as between private and public institutions. Financial hardships are very real. Over a third of expenses are paid out of pocket yet. Keep in mind that the average annual income in Kenya is roughly $7,000 US a year. This is the equivalent of about $18 a day. Lastly, sociocultural barriers still exist in Kenya because some Kenyans simply lack agency to seek out care. So attempting to address these inequities, the African Inland Mission founded Theodora Hospital in 1915. Theodora was later renamed to Kijabi Hospital. And like Gunderson, Kijabi Hospital has a long historic history providing surgical education. In 1995, the hospital began providing formal medical internships for general medical officers. And in 1998, Dr. Mark Newton from Vanderbilt University started the Kenyan Registered Nurse Anesthetist program. This was first formally recognized or accredited in 2007. At the time, this was the only KRNA program in Kenya. The majority of these graduates go on to practice in rural communities. I think this really speaks to the hospital's commitment to providing rural care. In 2008, Dr. Rich Davis started the general surgery program, residency program with the help of PACS. So what is PACS? In short, PACS is a faith-based, non-governmental organization that utilizes rural hospitals to train African surgeons, with the mission being training surgeons that will go out and practice in rural communities throughout the continent. For residents, PACS provides housing, books, internet allowance, as well as a stipend that covers basic living expenses. Without the partnership of PACS, programs like Kijabi likely would not exist. As you can see below, success has been through a collaborative effort with several organizations. One thing that has made PACS particularly successful is their unique training model. They emphasize clinical skills and an apprenticeship model, similar to many Western countries. They pride themselves on academic excellence and broad spectrum exposure to different types of surgeries. Their weekly didactic conferences, adaptation of the SCORE curriculum, and annual in-service training exams, again, similar to many Western countries. I think this is important given the variable training other places in the region. PACS is dedicated to inclusion. Only 9% of surgeons in the Kaseska region are women, but over a third of PACS residents are female. And lastly, they're dedicated to working in remote areas. So in order to receive the stipend from PACS, graduates must commit themselves to practicing in rural, underserved, or faith-based hospitals. In 2010, Dr. Pollock published on the practicality and sustainability of the PACS model. In 2018, Dr. Van Essen and colleagues published a 20-year follow-up. What they found was 100% of PACS graduates practice in Africa. This is no small feat considering the brain drain that happens in low and middle income countries. 79% practice within their home country, 51% short-term, 35% long-term retention rates. I think the success has been self-evident as PACS is now has 23 programs in 11 different countries. They've expanded to include pediatric and orthopedic surgery. One of my mentors when I was in Kenya was Dr. Myrtle, and I think she's a poster child for the success of PACS. PACS graduate herself, she's now the assistant program director at Kijabi Hospital. So in reflection, I was motivated to find some commonalities between the Gunderson training model and the PACS training model, and what has really led them to be successful in addressing these disparities. Starting with recruitment, it's important to seek out driven individuals who are committed to practicing in rural underserved areas. Oftentimes this means recruiting individuals who have prior life experience in a rural setting. In terms of education, exposure to a broad range of surgical procedures is critical. And with regards to retention, it's important to know that I think monetary incentives and financial reprieve, it's an important tool. For Gunderson graduates, this means, oftentimes this means reduced med school tuition and loan forgiveness. For PACS graduates, that means a stipend while in training. One thing I haven't really touched on, but would like to touch on is the importance of fostering community relationships and having a supportive network of like-minded rural colleagues cannot be overstated. So in conclusion, concerted efforts to support rural surgical training can lead to empowerment of trainees, surgeons, hospital systems, and rural communities. This has proven true both in Wisconsin and Kenya, in my experience. And I think these principles can serve as a foundation for addressing rural disparities, both domestically and abroad. With what brief time I have left, I'd like to give several thank yous. Thank you to Dr. Johnson, Dr. Jarman, Gunderson Medical Foundation for affording me this opportunity. Thank you to Dr. John Tarpley from PACS for letting me take time out of his very busy schedule. And lastly, thank you to Dr. Davis, Dr. Keeney, and the people of Kijabi for welcoming me into your home. I have several references. I'm happy to take any questions on the experience.
Thank you, Dr. Groban. There is a moment for a couple of questions from the audience. Is there anything that you learned that they're doing there that we could do better back home at Gunderson?
Yeah, I think as committed as we are to broad spectrum training, they take that experience to a whole another level. You know, I have the opportunity to do a craniectomy in Kenya, which is probably not something we would be able to do here in the U.S. Before fracture repairs, orthopedic procedures, they really take that broad spectrum experience to the next level.
From Cambridge, Mass. So it's a continuation of that question. Based on the rotations that you had in Kenya, have you guys looked at your case volumes there and experience there and helped change the curriculum? And you're looking at your title, I thought you were going to make recommendations. So I was wondering, the program directors here, have you guys thought about changing your curriculum to reflect maybe a complete curriculum for rural surgery?
Yeah, so that study performed by Dr. Esquivel in 2018 looked at case volumes between residents, and what we found was that our case volumes were actually higher month to month while residents were on these international experiences. So not only were we getting volume, we were getting the broad-based exposure. In terms of changes in future changes to our program curriculum, certainly we would like to continue doing these international electives as part of our curriculum. I think we're always looking for ways to continue to expand our exposure to broad-based sort of care.
Great talk. And a couple of questions. Which year you residents are doing this rotation, for how long, and while you were there, were you able to see your competencies and then the local residents, how do they match up?
Yeah, great question. So in terms of answering the second part of your question, that was probably the thing I came away most impressed with, was the quality of the surgical residents that I was working with. I would say, by and large, their junior residents are far more well prepared than most of our junior residents. And some of that was probably because they were recruiting general medical officers who had been in practice for years prior to joining the residency program. That was, initially it was explained to me that my role would be teaching some of the junior residents, but they were often teaching me several of these cases that I had never experienced or seen before.
And how long was
Yeah, so our third and fourth year residents go for roughly a month experience. So I was there a little bit longer than that. I was there about 5 weeks.
And were you able to count those cases towards your?
Yep. So all the cases I performed in Kenya, whether they were endoscopy related or in the OR, all counted through ICSUS and PBS.
Thank you, Dr. Grogan. Our next speaker is Dr. Lee Trombetta, and I'm proud to say he's one of my partners at Gunderson Health System in La Crosse. He's also the director of surgical simulation for our residency program, and he's also formerly from the Army, and in fact was stationed at Brooke Army Medical Center with several deployments. We're lucky now to have him in the private sector with us. As part of his practice at La Crosse, he also does outreach in a small town called Hillsboro, Wisconsin, in a critical access hospital. So today he will share with us how he developed the breast program basically as part of his outreach there.
Thank you, guys. Almost lunchtime. It's tough to follow Dr. Grogan's excellent presentation there. I'm going to share with you today some attempts I've made to start a rural surgery breast program in Wisconsin. I have no disclosures other than that Dr. Johnson is my boss, so I hope this goes well. I'm a general surgeon currently employed in the Gunderson Health System. Our main campus is in La Crosse. Our system has several satellite facilities spread out through La Crosse, or through Wisconsin and Iowa. Total catchment area is about 700,000 people. We have about 33 clinics. We border on the Mayo system to our west, University of Wisconsin system to our east, and Iowa to our south, University of Iowa to our south. Access to breast health in the rural environment is challenging. We have mammography offered in 17 of our locations. Breast MRI is only available at our main campus. We have an actual breast radiologist, actual radiologist in 4 facilities, and fellowship-trained breast radiologist only at our main campus facility. Breast surgery is only available in a limited capacity at 2 centers outside of our main campus. At our main campus, we are a NAPBC certified breast program. As per the NAPBC guidelines, all of the listed specialties are available at our main campus. This busy slide shows our breast cancer numbers since 2014. 2022 was our busiest cancer year ever with 353 new cancer diagnoses. We have 4 surgeons in La Crosse right now that perform breast surgery. Myself and Dr. Johnson and one other person are general surgery trained who do breast as part of our practice. We have 1 fellowship trained breast surgeon. In 2017, I started going to Hillsboro, Wisconsin, which is about 55 miles from La Crosse, to do outreach work. The population in Hillsboro is about 1,400 people. They just built this gorgeous, brand new 13-bed critical access hospital right on the lake, right in the center of the town. There are no in-house surgical services available, but there are several subspecialties that do outreach work in Hillsboro. My personal outreach practice in Hillsboro is now 3 days per month. I go every other week. 1 week I go Monday, the next week I go Monday and Tuesday and stay the night there so that I can try to do some more complex cases and keep patients overnight. My practice there is obviously, like all rural surgery practices, heavily weighted towards endoscopy and bread and butter general surgery. In 2021 at our main campus, we were experiencing sort of a backlog of breast cases, and this was kind of in that post-COVID where we started doing mammograms and everything again. We had a big rush of breast cases that needed to get done. And I raised the question as to whether or not I could start performing breast surgery in Hillsboro, in a hospital where breast surgery had not been done previously. It's important to note that if you read the American College of Surgeons Cancer Guideline materials, the COC guidelines, centralization of cancer care seems to be a core tenet, whether it's explicitly mentioned or implied. So I wondered if it were possible to provide adequate breast cancer and breast care outside of a major referral center. So to those in this room who practice in a rural environment, the advantages of providing care close to home for patients are evident. Travel is burdensome and expensive and time consuming, and sometimes not even possible in the middle of the winter time in Wisconsin when there's a tremendous amount of snow. Rural hospitals tend to be a super high impact employer in the communities. For example, the hospital in Hillsboro employs about 200 people in a town of 1,400. So the hospitals are a key business entity in rural communities in the Midwest. Broadening services in rural hospitals has benefits for revenue, staff recruitment and retention, and the intangible effects in the community of fostering trust and pride in the local healthcare facility. Literature is sparse. I know we're short on time. I won't belabor this. This piece out of New Hampshire shows that when breast surgery is offered in a rural hospital, delays to treatment are significantly lower than in urban centers. And then this piece out of Vermont basically says that efforts to improve rural breast surgery should focus mostly on access to care. So, in July 2021, I decided to try to start doing breast surgery in Hillsboro, Wisconsin. I began soliciting help from the key players in the process, which would be radiology, pathology, nuclear medicine, and I very quickly ran into significant formidable barriers. At Gunderson, we use radioactive seed localization to localize non-palpable breast tumors. This obviously could not be done in Hillsboro since there's no radiology support there. In addition, specimen mammograms need to be done after the completion of breast conservation surgery, which we also had never done there before. The radiologists at Gunderson were 100% supportive of my efforts, but there were significant logistical barriers. For sentinel node excision, injection of radiotracer is required. While this is injected usually by the surgeon, it doesn't require a radiologist or a nuclear medicine specialist. This had never been done in Hillsboro. Nuclear medicine did exist, but only in the context of doing bone scans for bone densitometry. Lymphoscintigraphy had not been done. Pathology was also a barrier. You have to have a special license to transport radioactive materials. You can't just transport them in a normal courier system. In addition to that, the pathologist did not want me to do mastectomies because due to CAP guidelines in a certified NAPBC breast program, a mastectomy has to be grossed in within an hour, because if you put it in formalin and it sits for more than an hour, there's not enough formalin penetration to the actual tumor, and it affects the ability to determine estrogen, progesterone, and HER2 status. So those specimens have to be cut up and grossed in so there's formalin penetration, and that obviously can't be done in a hospital that's geographically separate from the pathologist. The gamma probe that you use to find the radioactive seed and the sentinel node, this is the actual quote that I got at $60,000 for the gamma probe. A lumpectomy reimburses $3,000 according to Medicare. So how many lumpectomies would you need to do to make up for the price of the gamma probe? Quite a bit. And then, as noted previously, the multidisciplinary specialty approach that's required by the NAPBC is not possible in an area where there's no specialist located. So how did we overcome these barriers? Well, it took 6 months in order for us from inception to doing our first breast case. We were able to surmount most of these barriers. First of all, I did acquiesce to our pathologist, and I decided I would not push the issue on doing mastectomies at the rural hospital. On a side note, one thing that I did realize was a lot of the same administrative and technical support that you need to do breast surgery in a rural hospital is the same stuff that you need to do melanoma surgery. So a nice side effect of this is now that I can also offer melanoma surgery at the rural hospital in the context of sentinel node. The radioactive seed marking technique that we use can be placed up to 10 days in advance. So the patients can get the seed placed in La Crosse and then have their surgery scheduled in Hillsborough within 10 days. And we were able to contact a third-party vendor to deliver the radio tracer to Hillsborough for me so that I could do the sentinel node injections myself. And we do not do lymphoscintigraphy imaging prior to sentinel node for breast cases, so that wasn't an issue. The $60,000 gamma probe, I was able to borrow one from La Crosse. We have 4 of them, and right now I still have it borrowed. That's obviously kicking the can down the road on the problem, but in the short time I was able to surmount that issue. There's no portable mammogram machine in Hillsborough, so I developed a plan where when I excise the specimen, I actually hand carry the lumpectomy specimen to radiology myself and do specimen mammograms on that mammogram machine that they put patients in. And then I put the specimen into formalin myself in the radiology suite, confirm the presence of the seed with another nuclear medicine probe in radiology, and then it goes from there. And then I go back up to the operating room and close the incision. The images are then sent digitally to La Crosse, and a breast radiologist in La Crosse calls me on the phone in the operating room in Hillsborough, and we go over the films together to ensure that we got adequate margins, etc. We found a courier that could transport the radioactive material. The specimens are then taken straight from Hillsborough to La Crosse with our end-of-the-day courier run. And then the pathology technician in La Crosse explants the radioactive seed to complete the chain of custody for the radioactive seed. Then the patients are seen in multidisciplinary clinic in La Crosse, consultations to medical oncology, radiation oncology, genetics, social work as needed. I have 1 year of data, and this is not really a success story. This has been rather frustrating and not nearly as fruitful or as helpful as I had expected, which I think is one of the reasons I wanted to present it today. I've only been able to muster 13 cases in the first year of the program, while I did 160 other cases during my outreach time in Hillsborough. So I have a high volume practice in Hillsborough and outreach, but I'm just not getting the breast cases to go there. All the cases we did were ASA 1 or 2. They were all done under sedation with the use of a CRNA. 2 were DCIS, and the rest were high-risk benign lesions. I've yet to do an invasive cancer there, so I haven't been able to implement the sentinel node protocol that we worked so hard to develop. I will say that the system and the protocol that we have developed for these cases has worked flawlessly. We haven't had any near-miss events with lost seeds. We haven't had any miscommunications. We haven't had our courier crash and spill radioactive material all over the interstate. We haven't had any of those adverse things, but the volume just hasn't been there. Put it in perspective, in Hillsborough, during this first year, I did 173 total cases, including the 13 breast cases, and the breasts were 7.5% of my practice, whereas in my practice on main campus, I did 360 cases, with 165 being breast, which is 46% of my practice. So I like to liken it to that movie, The Field of Dreams, where they say, if you build it, it will come. Well, we built it, and they haven't really come yet. So it has been disappointing. However, I think there are a lot of positives. The system remains in place, and I'm going to persist. Since the time that I prepared these slides, I've since booked 3 more breast cases in Hillsborough. So I'm going to continue. There's no reason not to continue. So questions I have is, with a population of 1,400, how much breast pathology really exists in a town like that to have a breast program? And am I really offering rural breast surgery, or am I just using Hillsborough as my outpatient surgery center? Because if you look at those 13 cases that I did in Hillsborough, most of them were patients that kind of lived outside La Crosse who just decided to go to Hillsborough because they could get their surgery faster. And that's okay if that's what I'm doing. If I'm using our critical access hospital as my surrogate outpatient surgery center, I think that's okay also and has some benefits. I just don't know if there's enough breast volume in a town that size to support a real breast practice. The other thing is, I'm not really a rural surgeon. I'm a surgeon at Gunderson in an academic center that does outreach work. So I have the ties and the roots at the tertiary care center in order to do these types of things, whereas I think that a rural surgeon by themselves in a town like this, sort of on an island without those types of connections, it would be difficult to initiate a program like this. Did I really save the patients anything? They still had to drive to La Crosse to get their seed placed, and they still have to drive to La Crosse for their multidisciplinary appointments. They still have to drive to La Crosse for the radiation therapy. I think I did. I saved them several appointments. I see several follow-up patients. I've seen 30 clinic consultations for breast care in Hillsborough. So I think there is a positive effect on decreasing travel time and making it more accessible, but certainly not a huge impact. So I'm discouraged, but definitely not defeated. I think that high-quality breast care can be provided in a low-volume rural hospital if the support of the regional breast center is there. I do think that I've built trust in the community. I've given 2 community lectures there's a brewery in town. I've given 2 lectures at the brewery. We're well attended with 30 or 40 people on breast cancer, sort of community engagement type lectures. I think I've greatly helped increase the skill set of the operating room staff. It's always great it's amazing how operating room nurses and techs love learning new things and doing new things. And I think I've been a good resource for primary care. I think that the primary care base in Hillsborough is very solid. And I think now knowing that I do breast surgery in Hillsborough has opened their eyes. And I think I've become a good resource for them, even on benign breast things like lactational difficulties, breast abscesses, mastitis, those types of things. And I think that's helpful. So I'm hopeful that I can grow the program in the future. It's just a matter of fine-tuning and evolving the program in conjunction with the Regional Referral Center. And that is all.
I am that rural surgeon on an island trying to build a breast practice. It's something I'm very passionate about. I have two questions. One is with the radioactive seed, do you actually have a Savvy Scout that you're using to localize the seed intraoperatively?
So we use iodine 131 seeds, and it's the same as the gamma probe. So the gamma probe has a function that you can switch to technetium for the sentinel lymph node, the lymphoseek, and then it has another mode on it for the iodine 131.
And that's a function of your gamma probe?
Yeah, that mammatome probe has several functions on it. You can switch between radio tracers.
I say
The Savvy Scout, it's an RFI-based technology.
right.
And the problem with the Savvy Scout, we looked at that in our institution, was that the price of placing the marker is actually more than you get reimbursed for the lumpectomy.
Right.
So it actually becomes a net loss using that. Now, there are other advantages because it can stay in for months and months. So for scheduling, it makes it a lot easier. But we use this seed for that reason. The nice thing about the Savvy Scout as opposed to this seed, I know that's not the topic of this discussion, but the nice thing about that is you don't require nuclear medicine support.
Right.
And you don't have to go through all the Nuclear Regulatory Commission paperwork and protocols with the RFI-based technology.
I'm currently at the mercy of a radiologist who will come place a wire once a month.
Right.
So, the other question I had was, I'm in a community where they don't even want to drive to get radiation, so I do mastectomies the vast majority of the time. And I was just wondering if you had any tips on how to convince them to do breast conserving therapy.
I do not, admittedly, in our region, and Dr. Johnson can attest to that, we have a markedly high mastectomy rate in central Wisconsin, almost 3 times the national average. I routinely do bilateral mastectomies for sub-centimeter DCIS, and it just seems to be patient preference in our area. So I face the same problem in that I don't know, I don't want to say I want to encourage breast conservation because obviously it's an informed choice, but at the same time our mastectomy rates are astronomical in our region, and I don't know the answer to that. And we've looked at, one of our residents a few years ago studied that based on zip code, thinking that the lack of access to radiation therapy may prompt people to pursue the mastectomy route because they don't want to travel for radiation, and we just could not correlate it with distance living from the hospital, with zip codes or anything like that. It just seems to be regional preference.
Hi, Erica Fellinger, Cambridge, Mass. Great, you to be commended on your efforts to get the program going. But I'm wondering 2 things. One is, have you considered maybe trying to shift your efforts to make the visits that the patients have to make in La Crosse as condensed as possible? I mean, I work in an urban area, but it's, I'm trained in a rural area and I'm from a rural area. And actually, even in the urban area, there's some similarities of people who can't miss work, don't want to miss work, don't want to cross the river. And we try to make it worth their while when you're having as much done as possible on the day that they come down. And secondly, my question is, have you considered making, is telemedicine, televisits part of the practice at all, especially since the COVID pandemic has kind of expanded the willingness and existence of those? Thank you.
Yeah, great questions. So the first one is we do that. We actively try to condense visits in 2 phases. The first is the diagnostic phase. Our radiologists have a system where they'll do diagnostic imaging, extra imaging, and biopsy all on the same day. So they're booked for a diagnostic radiology consultation where they do everything at the same time. On the back end, after surgery, they do have a multidisciplinary appointment where they see radiation oncology, medical oncology, surgery, and social work and financial counselors, all during the same appointment. It's about a 4-hour-long appointment where everyone kind of rotates through to take their turn. So we have made an effort to condense that. And then what was the second question again?
Televisits or telemedicine?
Yeah, I think there's potential there. Dr. Johnson and I have both sort of actively tried not to do that. I think in the breast realm, I struggle a little bit with I mean, you can't do a breast exam over telemedicine, and we've not, our nurse navigators do a lot of counseling over the phone, and we do phone consults. We have not embraced telemedicine for some reason that I can't really put my finger on, but that is a potential.
Again. I'm not a rural surgeon, and I also don't know the breast surgery, so with that.
So sit down.
With that. But I had a system question for you. So maybe you're you're trying to solve a problem that doesn't exist. What I'm saying is, maybe the patients want to come to lacrosse because there's a perception out there. If you have a really great program at lacrosse, anything else is less of value, and they will not go anywhere else. So that's something it's worth looking at. What the opinions about having a program outside of lacrosse. And the other issue is looking at your database and say what your zip code is. Maybe Hillsborough is not the place, maybe it's another place nearby where there are more patients who are going to come. So I think those are two things that I would do if I have to relook at how to reorganize it, see where maybe the patients are not in Hillsborough, maybe somewhere else, and also whether they want to come to Hillsborough or Gunderson. And you can still have it at Hillsborough for the post-op adjuvant treatment, which you already have them. Now you already have the surgeon, but the adjuvant treatments can be done in Hillsborough.
You have put into words exactly most of the thoughts I've had over the last year with this program. And I've pulled this slide back. The power of that sign on the wall, that it's a breast center. All the same surgeons are in the breast center that are across the street in general surgery clinic. But the power of having a sign on the wall that says breast center is extremely compelling for patients. So you're right, it is hard to get them away from the mothership when the perception is that they have to go there for their breast care. Breast surgery is PGY1 level surgery. I've let med students do a lumpectomy. It does not require tertiary care level skill set to do breast surgery. It's more than easy to do at a small community hospital with a surgical first assistant. But the sign on the wall is tremendously powerful. I agree with you 100%. And you're exactly right. I've asked myself all these questions. What should this program look like? Making Hillsborough a breast center is not the way to go. That was sort of the initial goal. That's not the direction. The goals and the intentions and the endpoints have to evolve in order to make it something that's worth doing. Thank you.
Thank you to all of our presenters today. And now I believe we break for lunch.
Hey, how you doing? Good to see you too. You